Hello there.
Hello.
Thank you for joining for the latest edition of Optom Ask. Just go straight to asking questions, I guess.
Yep.
And the first question I always ask everyone is just tell us a bit about yourself.
Well, my name's Heather Locker. I'm one of the Orthoptists in Singleton and Binocular Hospital, and I've been working here for almost 7 years. I specialise in stroke, cerebral vision impairment, and I also work in the glaucoma clinic as well.
Very busy person. All right. First question is, what do you expect the normal refractive error for children?
So if there's no esotropia or exotropia and no sign of like visual acuity issues, then any sort of hypermetropia of like even below 4, so 3.5 would be a fairly normal prescription as well, or below that, that's fine. Myopia up to about 1 diopter, not too concerned about, and astigmatism or anisometropia sort of 1 or below, again I'm not too concerned about. There's quite a lot of changes all happening at that early stage, so just monitoring, and if it starts affecting visual acuity or causing any other issues, then that could be when you could step in for it.
Fantastic. And either prescribing the glasses or referring to the Orthoptist department?
Yeah, you could always prescribe the glasses if it looks like it's going to be helping with the visual acuity, or like for an esotropia or something like that, and then referring if it's not being sorted out.
Very good. And that leads us to the next question. What is the importance of a good cyclorefraction?
So cyclorefractions are a lot more accurate, especially for young children who are not always consistent with their accommodation or staying still. So it's going to give you a lot more information, especially if part of their condition is that they're accommodating a lot, especially for hypermetropia, esotropias especially. But even something like a accommodative spasm, you're going to get a lot more information out of it, and you just want to make sure that they had enough time for the cyclo to set into work, so you want to give about 20 minutes at least.
Right, because often if I wait 10 minutes and I call the patient back in,
that's not good enough.
and you still get that accommodation, you're wondering, oh my god, what do I do next?
You need a little bit more time for that. Half an hour is great, but 20 minutes you do really well.
Fantastic. And what would you give when would you give a partial or full refractive correction?
So we tend to give full refractive correction if it's like myopia, and for hypermetropia we tend to only give it if it's if they've also got an esotropia, because we want to completely correct that accommodation. But if there's like an anisometropia or high hypermetropia but there's no esotropia, then we might look at doing a partial, and just to try and help the ametropization process still have a bit of improvement possible. We don't necessarily need the full strength of hypermetropia unless there's an esotropia there.
Fantastic. A lot of primary care opticians have this Cardiff cards. Briefly, how would you use it?
So you can do it at 50 centimetres or a metre. You just want to be careful that you're actually doing it at that distance. I tend to do for both eyes together first, because it's a lot easier than testing monocularly for this sort of like a toddler age group. So try and do both eyes open, just working down from the big ones to the small ones in fairly big chunks. If they're struggling, then you can always go up, but you're going to lose their concentration very quickly. So skipping down, and then we're expecting, like if they're like a 2-year-old, then like 0.3 isn't far off what we'd expect anyway. So getting that sort of level after a couple of cards is going to help, and then you can start looking at monocular testing. I tend to test with my hands, or getting the parents' hands to cover, because trying to wear the baby glasses is not always very good, and they tend to be pretty good at taking patches off by that point. So yeah, just if you can get a monocular test, that's great, but even binocular is really useful.
Fine. And you mentioned the different distances. Was there a particular point where you changed the distances, or does that matter?
So the cards are just set for like what it's measuring at 50 or 100 centimetres. So as long as you're doing it at that distance, I'm not too concerned. Sometimes it's a little bit easier to engage with the kids if you're at 50, but 100 metres is probably a little bit more consistent, just because a little variations isn't going to make so much of a difference in the acuity score.
Fantastic. And when The next question is, when parents start handing you the school screening tests and they've said their kid has failed, often enough there's a sense of panic from the optom. How would you, what would you recommend, what advice would you give optoms?
To be honest, it's just a normal glasses test that you're doing, general health check of the eyes, check visual acuity, check if there's any refractive error. A lot of the time they might have just got a bit nervous when they were doing the test before and they just didn't do very well with the letters, especially if they're not very confident with their letters, because they don't use like any pictures on the test. So just treat it as a normal test, but that form that you get with it, it's really useful for us because we collect all and it goes through an audit. So if you could send all of the forms to us, that'd be great. And then we could just make sure that that the kids who are failing, they're actually getting the test done. Because sometimes it comes back and we only get like 30% of the forms back at best, and then we don't know if those other 70% have had the test and the form's just gone in the bin, or if they never had the test. So it's the more information we get, the better. Always
Send them back to your Orthoptist department.
Yes.
Great. Can optoms patch?
It's a little bit of a, sometimes we do get people come in with patching. I'm not a big fan of it because there are some risks involved that maybe they don't have the equipment to check in primary care. So really the sooner, if someone's looking like they need to patch, like if they've got a lot of anisometropia or a lot of visual acuity difference early on, I'd recommend more like sending in early referral rather than waiting to see if the vision improves after the refraction to start with. If it looks like it's going to be needed to patch, because if you start patching and they're a little bit older and they've got something like a microtropia, which might not be super easy to pick up, then there's chances of that decompensating or causing like diplopia that we don't want to happen. So it's just making sure everything's safe.
Just being very cautious.
Yeah.
Well, key points when someone's complaining about double vision. That's another common occurrence in primary care. Patients coming with double vision.
Yeah, so it's quite useful to know if it's something that's been going on for a long time and just gradually changing, or if it's a sudden onset. We'd probably want to get you straight into us and get that checked out. But if it's a gradual onset, then looking to see, like, it might be something that's decompensated, or it could be part of like a slow changing condition as well. So for any double vision, you want to be checking like a cover test and checking ocular movements really carefully as well, and just to see what's going on, what's causing it, at a rough idea. If it looks like it's something that's just gradually decompensating, no particular muscle issues found, then it might be something that could just be strengthened up, whereas if we find a cause, then we just want to do further investigations to find what the cause is.
Right. Well, you would do the cover test in all these sort of gazes, particular gazes, or? Yes,
yeah, especially like if it looks like there's any vertical deviation, and then doing a cover test in like oblique positions is going to be really useful, just because it's sometimes really hard to tell if there's little underactions or overactions in those positions without a cover test.
Very good. Eye exercises. I'm pretty sure there's more eye exercises than your pen to nose.
Yeah, there's a few that we do after that. Pen to nose is alright. It's not the best one, but it's a good starting point, especially if your convergence is quite far away to start with. You might need a little bit of work before we go on to the later ones. Dot card is something that we use quite a lot, and it tends to get that improvement a little bit faster than pen to nose, but a lot of it is about technique. So wanting to check if rather than just having it and then bring it closer, go single, bring it closer again, it's about trying to use the eyes together and kind of keep it single. So I tend to say to them, once you've got it single, rather than bring it straight away closer, try and hold it for 5 seconds as single before you bring it closer, because otherwise you get people who are coming in and they can get it really close, but they're still having a lot of symptoms because they can't maintain it.
Fair enough. There's so many different variations of a pen to nose. I got taught that just bring the zigzags in and just straight, and
I don't know about the zigzags, but
that's what I got taught. And finally, What do you think of optoms prescribing low prisms?
I'm not a big fan of prescribing low prisms. If someone is showing a little bit of weakness in the binocularity, then prisms can sometimes cause further decompensation. Like if it's an exophoria, or even an esophoria as well, especially horizontal ones, they could end up relying on the prism a little bit more, and then that strength that they could previously use to control it gets weakened, and they're more reliant on it. Vertical ones are sometimes useful. Again, a lot of people, if they've always had a vertical phobia, they might have been able to control that before, and it could again decompensate. Especially if they're not complaining of double vision, I would definitely stay away from prisms. It might sometimes be useful, especially like you might often get things back from us saying, please can you incorporate prisms. That's great, and some people do really benefit from low strength prisms, but it's just being a bit cautious about it.
Right. Fantastic. I think one question that I want to ask is about the fixation disparity unit that we use as optoms. It's not commonly used in
no, we don't.
In the optics departments. I think that's why a lot of optoms use the low prisms and that. But
yeah, if someone's not got any symptoms of double vision or the sort of asthenopic symptoms, I'd be very, very cautious about even looking at prisms. If they have got signs of BSV issues, then it might just be worth sending in a referral for it.
fantastic. Thank you very much, Heather.
Thank you.